Hello, everyone. Sorry for the delay, but we are just going to start immediately. It's our excitement to welcome you to another session of ISSUP Nigeria bi-monthly webinar tagged ISSUP Nigeria Knowledge Update Series. For those who have been following us, this is our 22nd session, and today we will be discussing a very important topic: therapeutic community as a model in the management of substance use disorders. Once again, my name is Ejikeme McBishops Okweji, and I'm the head of the ISSUP Nigeria webinar and editorial team. Joining me to lead the moderating panel is Dr. Martin Aboge. Dr. Martin Aboge is the president of ISSUP Nigeria. But before I introduce the speaker, let me just emphasize that the information presented in this session represents the view of the presenter and not those of ISSUP Nigeria. It is not medical or treatment advice. I would also like to inform you that there will be an opportunity to ask questions during the webinar. Please use the chat box to submit your questions as the presentation is ongoing. After the presentation, we will address your questions. On this note, let me introduce our speaker for today. Our speaker today is Mr. Nduka Augustine. Mr. Nduka Augustine obtained his Bachelor of Science degree in Biochemistry at Obafemi Awolowo University, Ile-Ife, in Osun State, Nigeria, and holds an advanced professional diploma in criminology, terrorism, and intelligence studies of Nawa Institute of Science and Technology, Nigeria. He worked briefly with Norman Engineering and Construction Company Limited and Synergy Systems Limited, a software support company, before enlisting into the National Drug Law Enforcement Agency, NDLEA, in 2001. He has served in different states and in different capacities with the NDLEA, including as Principal Staff Officer, Drug Demand Reduction. He has received several trainings in addiction-related fields, including training on management in health and monitoring and evaluation in global health from the University of Washington. Introduction to Evidence-Based Prevention, INEP, course from the First Medical University, Charles University Prague in Czech Republic. He also has certification in drug prevention, treatment, and care, DPTC, of the United Nations Office on Drugs and Crime, UNODC, and Colombo Plan Universal Prevention Curriculum, UPC trainings. Mr. Augustine is a Universal Treatment Curriculum, UTC National Trainer in Nigeria, an internationally certified addiction professional, ICAP 1 of Colombo Plan DAP, a member of ISSUP Nigeria, and also a member of ISSUP Global. With this impressive background, I'm excited to introduce our speaker for today's webinar, Mr. Nduka Augustine. Mr. Augustine, the floor is yours. You're welcome. Hello, Mr. Augustine, can you hear me?
Yes, I can hear you, sir.
Okay, please, you can carry on.
Thank you very much, Ejikeme, for the great introduction. I want to also appreciate our President, Dr. Martins, and the entire leadership of ISSUP Nigeria, and our international guide, Kwado, who has been very wonderful in guiding me all through the process. I appreciate so much. The topic we are having today is therapeutic community as a model in the management of substance use disorders. And the topic is apt and necessary. The topic is apt and necessary because of the increasing relapse cases we found in our normal treatment and rehabilitation modalities. And it became very important that new methodologies should be found to ensure that the rate of relapse and the outcomes in treatment is improved. And that was why when I listened to the INL sponsored recovery in workplaces in 2021, the therapeutic community model was mentioned, and one of the models that have a lot of participants, up to 1,200 or so in the community. I said, wow, I started making contacts, and that was what informed my interest in this model. As a way of content, we'll look briefly at objectives and introductions, and we'll overview some of the addiction treatment regimens we had before. We talk a little bit about the therapeutic community models we have in Nigeria and maybe Africa and the UK and in the US. We'll look at the perspectives of therapeutic community, looking at how do they view the disorder and how do they view the individual that is having the disorder. What is their opinion of right living and what is their opinion of recovery? Importantly, we'll also look at the community as method, because the community has become one of the major methods of recovery for people with SUD and other mental health challenges. Then we'll look at basic components of the TC model and the processes. And finally, I will actually look at San Patrignano, which is a community in Italy, one of the world's most populous and recovery community that has really done so well as a model. And I believe finally, if we're able to do that, we'll have some concluding remarks and recommendations on the way forward. Can I move to the next slide, Pado? Then, in terms of the objectives of therapeutic community, and generally, it is to use the patient's social environment, which is the social environment in the community, to provide therapeutic experience for the patient. Second objective is to enable the patient to be an active participant in his own care and become involved in the daily activities of his own community. Then it's also to help patients solve problems, get involved in planning activities, and to develop necessary rules and regulations for the community. The patient is important in developing all this, and by helping to do all this, he learns all these skills and becomes part of him, internalizes them, and it helps in his recovery. Then it's also to increase their independence and gain control over many of their own personal activities. The community helps clients within the community to be able to acquire or gain control over their lives, because these are people who are naturally dependent on people who are not independent as a result of drug use. So by giving them opportunity to help in planning their activities of their community, getting involved as role model, looking on to people who have progressed through the system, they are able to gain greater control of their lives. And finally, it is to enable the patients to know how their behavior affects others. Most people with substance use disorder, they are not able to have this insight. So these are some of the general objectives of therapeutic communities. Then, next slide, Pado. In our learning outcome, at the end of the presentation, we will have highlighted the earlier treatment models and approaches used to treat substance use disorder, and may say a little bit about their efficacies. Then we should be able to have a good understanding of the therapeutic community model of recovery, their philosophy, their approaches and processes and operations. And we will highlight the unique features, practices of San Patrignano community in Italy, which is one of the models that we have adjudged and to be very, very effective. And we are also going to garner support for adaptation and transfer of successful theses, such as San Patrignano, to other countries, such as our country, Nigeria. There are a lot of reports. The community have been studied. It has been transferred even to adapted and transferred to Scotland. And in a lot of other countries, the model have been also adapted and transferred. My definition of a therapeutic community, a British medical journal, Tom May, coined the phrase therapeutic community to describe an organized, a place organized as a community in which all are expected to contribute to the shared goals of creating a social organization with healing properties. Everybody is contributing to create a social organization with healing properties. That's Rappaport 1960. Then it's also a structured environment, a structured method and environment for changing human behavior in the context of community life and responsibility. A therapeutic community is a treatment facility in which the community itself, through self-help and mutual support, is the principal means for promoting personal change. We're saying that when people are in this community and it's a structured community, there are do's and don'ts, there are learning processes, both vicarious and conscious ones. Then we also know that it's a therapy in which patient social environment will be used to provide in introduction, substance use disorder is a global social public health challenge facing the entire world. Our Nigerian Drug Use Survey 2018 estimates about 14.4% of people aged between 16 and 45 have used illicit substances. And from that report, we have an estimated 376,000 of high-risk drug users. 80,000, nearly 0.1% of the adult population, are estimated with as persons with injecting drug use, involving men and also women. It shows that there are increases. This is just Nigerian statistics, and all over the whole world, the figures are increasing. And in law enforcement, we have seen increasing sophistication of and mode of concealment, innovative modes of concealment of drugs. This is cannabis that we see by the right-hand slide, but there are methamphetamine, there are other drugs. We've seen these figures rising all over the whole world. And the expectation is that the burden of drug use and the population of users is going to increase. And that's why it's important to have a model. Before now, the disease model is what we have been practicing, or we have been looking at, one of the current models that sees addiction as a disease of the brain circuitry. And the guidance or the direction is to treat it as a disease. And that's why we are actually saying that there is a shift from this disease model, there's a shift from this model to now seeing a recovery center solution where you recognize the wider social determinants of addiction. That is not just the drug itself. There could be family issues, there could be environmental issues, there could be genetic issues, there could be other social determinants, population, lack of job, that could predispose people to begin to use drugs. And you need to be able to address all that. Then SUD, of course, substance use disorder, have been described as a multifaceted health problem of the whole person. It involves his biological, involves his physiological, his sociological, his psychological dimensions. Then the therapeutic community model or approach have been found to be an approach that it will help to address most of these areas, all these determinants of addiction. And that's why we are saying that a multidimensional whole person's change is necessary. And of course, a multi-interventionist approach too. You don't just treat with the medication, other social approaches, counseling approaches, and a lot of other approaches are used to tackle the multidimensional approach. It's my hope to discuss some of the models, highlight the observed benefits of the TCs as a whole person, multidimensional, recovery-based, complex human intervention system. That's a TC. I will look forward to the opportunity of adapting and exporting successful TC models of SUD management, such as San Patrignano, drug recovery community in Italy, to be implemented in Nigeria and to be exported in other nations, so that a community, because averagely in some of our rehabs, you can take 10, 20, but we have families approaching us every day for space. And we seem not to be able to meet up with the army of young people who are having challenges with substance use disorder. And that's why a community that has, that can take up to 1,005, like the San Patrignano community, is a model that can be of help if government, if philanthropists, if political office holders, if policies are to be made such that such things are created and more people will have access to treatment. On approaches, earlier models, treatment approaches have ranged from pharmacological, psychotherapeutic, and psychosocial. When people have addiction issues, substance use disorder, is medication issues that are given, psychotherapy, psychosocial intervention. The first line of treatments are usually pharmacological. You give medications, and oftentimes you can do maintenance therapy or medication-assisted therapy, opioid maintenance therapies and all that. Then when it's not working, or you can now add non-pharmacological interventions, can be paired with both medication-assisted therapy that are largely psychological in nature and include MI, psychodynamics, therapeutic self-help group like Narcotics Anonymous and the 12-step program. Then there are other non-pharmacological interventions that have also been proven to reduce the complications due to drug use. And that will include harm reduction strategies like needle and syringe exchange programs, safe injection sites like is practiced in some of countries. Then of course, naloxone distributions to help people to be able to go to office while working on their addiction. These are some of the methodologies. But there are more impaired patients who are acute, who have intensive need of detoxification and all that. You find out that after applying some of these other methods, they still relapse back, they still need assistance, they still need to be cared for. And that is why these patients are taught to particularly benefit from an integrated recovery-focused approach, like the therapeutic community model, because they will be in that community. Therapeutic community, for instance, San Patrignano is a long-term rehabilitation program that patients can stay up to 5 years, 4 years, 5 years. That will be enough for you to learn skills, for you to internalize what is taught, for you to be able to become leaders, for you to become people that others will see. And when you go out, research have shown that rate of relapse is quite small in comparison to other models. There are communities like the San Patrignano in Italy and CELS in Rome, Association of Nova España in Spain, then Basta, a Swedish-run social enterprise. Then the futures is the primary therapist in it, the primary therapist and teacher in a therapeutic community consists of peers, consists of the community itself. The community as an environment is a teacher. People learn vicariously. People observe others. People learn in the community. So the community is an environment of its own, but it's a structured environment. There are also peers. There are also staff who are role models of successful personal change, who have also recovered, who passed through the system. Then the TCs also adheres to right living, truth and honesty, the here and the now. It teaches personal responsibility for destiny. You have to take charge of your own destiny. Social responsibility. It teaches them to be their brother's keeper. There's a moral code that your inner person is always good, but your behavior can be bad. It's trying to let them know that your behavior is not you. And these are all thoughts, are some of the features. Then the therapeutic community encompasses developing a variety of approaches that help avoid drug use, including recreational activities, relapse prevention methods. These are all there. In some of the essential elements, all aspects of the living together within the community provides an opportunity for learning experience. Everything, you make a mistake, you are corrected here and now. You have roommates, you have role models. You go to your workplace because there are workplaces within the community. You learn. Everything you do is a learning process. The TC staff with a learned history of recovery is encouraged to provide residents with role models. There is an expectation on members of the community to develop the capacity to be a positive role model as they progress through the program. As you stay, when new ones come, you learn, you become a role model, you move through the system, and you learn capacities, you learn skills, you also learn, there's so much they learn in the community. Then in the TC, you learn how to take responsibility for their recovery and impact their behavior has on their community. You make a mistake, you learn from it, you are guided to learn from it. The community takes responsibility for supporting the recovery process by challenging problematic behavior in a safe environment that encourages reflection and change. When you make a mistake, it will be challenged immediately. And people will help you, guide you with words that will enable you understand the mistakes you made. And you reflect on that change and learn and move forward. Little slide on the right shows a helping process. People learn to help, even without knowing that that is a statue. The young boy saw it and felt the other rabbits wants assistance to help the other one to come up. He just went. So people learn how to help, even without being asked in the process. In Africa, there are a lot of TCs. The African system have been built on community system. People help one another. People live in a community system. The traditional counseling is based on the African concept of unity. For instance, in Ubuntu means that they say, I am because you are, and you are because I am. Therefore, we are. A positive sense of belonging to one's family, harmony, unity, support, and care. There are support systems. Africans don't live themselves in a traditional way. Then the Egbado community, the Yoruba villages, have been participating in the handling of mental illness and is a community program. Then, of course, we remember the Uzoakoli leprosy settlement in Abia was a colony right from 1932 to 1992, did a silver jubilee, so a diamond jubilee. And these are a community of people having challenge. And it has been a practice that has been happening in both Africa and then in his book, Maxwell Jones in 1953 said the therapeutic community he noted that outside the therapeutic hours, the patient's hospital behavior was similar to the behavior he displays in his community. In normal hospital environments, mental health environment, Maxwell Jones noted that when work closes and the therapist goes, that the behavior of these patients is similar to what they do when they are in their home. And that's why they are proposing that the hospital environment should be made in such a way that people will learn, patients, mental health patients will learn to be able to outdo and learn to move ahead in their recovery in their mental health challenges. Of course, the traditional healing in Africa, almost the same thing. In African system, African people, they aspire above everything else to experience fullness of life and well-being here and now. And it's demonstrated by people asking you, how are you every morning? And they want to wait for you to tell them how you are. It shows that people are concerned, people are connected. There's a community in the African system. Of course, in the churches, mainline churches, even it's part of the gospel that they preach, that you should heal the sick. People should not be sick. And if you don't heal the sick, you are not going to prosper. So we have seen that therapy is encapsulated in the entire African system. Then in the UK, shortly after the World War, a British psychologist promoted efforts to bridge the patient's population in the hospital back into their community in order to support reintegration of traumatized soldiers back into society. Patients were so much in the hospital, but psychologists proposed that why don't we send them back into the community to support their reintegration and also help traumatized soldiers to recover. The UK model grew out of mental health hospitals, psychiatric hospitals, largely staffed by nurses and psychologists. In the late 60s, the concept of self-help tradition merged with the use of professionals, practice and staffing in the UK. It began to include people who had gone through drug treatment program. Initially, it was professionals, mental health professionals, but they now started to include people who have been treated through the process. That was why the therapeutic community was coined. In the UK model also, there's an idea of re-entry into the community firmly upheld. The alpha houses were established in 19, and the lay community was growing out of the little more psychiatric hospital. All these are emphasizing that in psychiatry and in the mental health hospital, it grew before it progressed into the other one. Then in the US, Charles Dendrick developed the cinnamon model, and it came out because alcoholic drug dealers were not comfortable in attending Alcoholic Anonymous meetings, or the Alcoholic Anonymous were not comfortable with drug users attending their meeting. So Charles Dendrick has to start a community, the cinnamon model, and it's based on the notion of self-responsibility, no acknowledgement of post-treatment phase. Persons with drug use disorder understood as a character disordered individual who couldn't sustain pro-social lifestyle in the mainstream community. The thesis in the US also recruited people who were not addicted as functional staff. In 1970, cinnamon transformed into an alternative lifestyle. What are the perspectives? How does the therapeutic community view the disorder? How does the therapeutic community view the individual having the disorder? How does the community view right living and recovery? The TC offers a systematic approach that is guided by an explicit perspective on drug use disorder, the person that is having the disorder, recovery itself, and right living. In the thesis, the primary therapist and teacher is the community itself, which consists of the social environment, the peers, the staff members, who are role models of successful personal change, and they serve as a guide in the recovery process. How do they view the disorder? Substance use disorder in the thesis is regarded as a disorder of the entire human person. Throughout individuals, Though individuals may differ in their choice of substances, abuse involves all areas of function, the cognitive dimension, the behavioral dimension. Mood disturbances will appear, medical problems will appear, thinking may be unrealistic, disorganized, values may be confused or non-existent at all, and of course antisocial behaviors are a norm for them. Frequently, there are deficits in verbal, reading, writing, marketable skills they may not have. Finally, in existential or psychological terms, they have moral issues that are involved. Abuse of any substance is seen as a behavior with multiple determinants. They view this behavior not just the drug that they are taking. Some of the models in treatment, when you come, you focus on the substance. We try to find out, is he taking marijuana? Is he taking cocaine? Is he taking methamphetamine? You focus on the drug. You keep counseling and ensuring that he stops drug use. But in therapeutic community, you are looking at the drug. You are looking at other social determinants of addiction, and that's how the progress continues. How do they view the disorder also? The problem is the person, not the drug. In the TC, you are not saying that marijuana the boy is taking is what is causing the problem. The challenge is in the human person, not the drug. Addiction is a symptom, it's just a behavioral outcome you are seeing, not the essence of the disorder. In the TC, chemical detoxification is a condition of entry, not the goal of treatment. You have to detoxify before the person have the mental health capacity to comprehend your counseling process. But that's not the goal of that. Then rehabilitation focuses on maintaining a drug-free existence. It's a recovery process. And people have peace of mind, not just in the amount of money in their bank accounts, just like we see a very young small boy who may have enjoyed the very sumptuous meal of the mother, and is so happy and relaxed, not minding what they view. How does TC view the person now? Rather than drug use patterns, individuals are distinguished along dimension of psychological dysfunction and social deficits. A considerable number of clients never have acquired conventional lifestyle. I came across rehabilitation and habilitation. Habilitation, there are individuals who are never taught, who have never been in a home, who are born under the bridges. They don't have a home, so you are not even rehabilitating. You are talking about habilitating them for the first time. Then vocational and educational deficits are marked. Mainstream values either are missing or unpursued. These persons, there are deficits in educational and vocational. What do they do? And that's why successful models like the San Patrignano community, there are vocational institutions, and is a social enterprise model. In other words, it produces up to 50%. The clients in the community have various professions they are pursuing, and in that they learn skills, they learn professions that they are going to use when they leave that community, and it's a long term. So in the community, the persons that are just entering may be deficits in a vocational or educational, then mainstream values are either missing or never pursued at all. Most often, these clients emerge from a socially disadvantaged sector where drug use is more a social response than a psychological disturbance. If you go under the bridge in Lagos, if you go under the bridges in certain other communities in our country and in certain other countries in Africa, you see children living unattended to under the bridges. That's a social environment, socially disadvantaged environment. And these young children, they are just responding out of the environment they found themselves. Some of them never have known their mother. Some of them never have known their father. Some of them may be raised with a mother that is addicted to drugs, who never gave them childhood upbringing in the first place. So these are the people that are welcome. Then in view also of the person, regardless of the social class or differences Person with substance use disorder have challenges of myriads of problems. Problem with socialization, problems with cognitive and emotional skills, overall poor self-esteem, conduct and character disorders, and just name it, inability to manage feelings, particularly hostilities. We've seen many of them fight in facilities. We've seen them, they have low tolerance for all forms of discomfort, and they can't delay gratification. Then they also have impulse control problem. They want it here and now. Then unrealistic self-appraisal, they are not able to, because the drug is in the brains. So the cognitive functions have been impaired. They are not able to have a realistic appraisal of themselves. They lie a lot, manipulative in nature, deception, problems with authority, and personal and social irresponsibility, inconsistent or failures in completing or expected obligations, present difficulties in managing guilt. Additionally, significant numbers have marked deficits in education and marketable communication skills. These are the individual. This is how therapeutic community views these people before they enter. How do we view right living? What do they want them to look at? TCs adhere to certain precepts and values as essential to self-recovery, social learning, personal change, and healthy living. Some precepts specifically orient the individual to priority be motivated by values of achievement and self-reliance. In general, sobriety is a prerequisite for learning to live right, but right living is required to maintain sobriety. In how do you view recovery? The aim of treatment are global in the TC. The primary psychological goal is to change the negative pattern of behavior, thinking, and feeling that predispose people to drug use. And the main social goal is to develop a responsible, drug-free lifestyle and a stable recovery. However, depends on a successful integration of this social and psychological goal. Stable recovery, we've seen many in our treatment modalities that can be for 3 months, 6 months, 4 months, short duration. They will tell you, I've changed. You look at their faces, you will know that they mean what they may be saying. But in the next few months, you see cases of relapse. There is a challenge of internalizing what you have learned, internalizing of your psychological and social goal. And that's one of the emphasis I've seen in long-term treatment modalities like 3, 4, 5 years program, like the ones in the therapeutic community. How do you view recovery? Behavioral change is unstable without insight. That's why all they learn, both vicariously, both the ones that are consciously taught, as they move within the community, they will have to internalize and have insight why they need to be doing that. And they are saying that insight is not sufficient without the learned experience. Thus, conduct, emotions, skills, attitude, and values must be integrated to ensure enduring lifestyle changes and a productive personal social identity. The social and psychological goals of the TC shape its treatment regime, as well as define several broad assumptions concerning views of recovery. The community as a method. We have earlier been saying that the community is a method. The community is a context, it's an environment, but it's also a method because people implement those modalities. The peers are there, the counselors are there, the teachers are there, and all are part of the community in helping the process. Features of a community as a method. Relationships are used, peers involve and teach others. There are open communication. People are open, counselors and all that. Hello, sir. Use of open communications, use of structure.
Yes.
And
Austin, hello.
yes, sir. Hello, sir.
Yes, we can actually hear you now, but we wish you can wrap up maybe within the next 5 minutes to allow for Q&A session.
Oh, okay, sir. Okay, sir.
Thank you.
So, yes, the community separateness, community activities, staff roles, peers as structured day work as a therapy. They learn work and their faces formats. Then I want to actually go ahead and look at some of the interventions. There are interactive ones, formal and informal, general community interventions, specific interventions, and all that. There are resident meetings in the small house you live. There are morning meetings. There's also a general meeting. There are breakfasts and all that where people meet in various social systems. Then there is self-change, identity change, and how to internalize what you have actually learned. You know, emotional healing, social relatedness, these are all experiences and perceptions that can change. Therapeutic role, socialization role, people help one another and help support one another and change. Then one of the models we've been talking about is San Patrignano, Italy, that is a social enterprise established or founded in 1978 by Vincenzo Musioli, and is a social enterprise, a capacity of over 1,300 residents, about 250 employees. And since 1978, they've handled about 25,000 people hosted in that community. And one of the most important things, like we keep saying, is that it is a social enterprise, talking about sustainability of the program, because government cannot keep supporting. They designed a way
Okay, I think we've lost the presenter. And as we wait for him to... Okay.
Yes.
You can
Then
continue.
Finally, we have all that San Patrignano, vocational training, leisure activities, sports, and the group method. Environment as a therapy, the environment. And the people fit together, you know, and so much has happened. Level of relapse is so small, it doesn't mean it's not there. But research have shown that people who stay throughout the long 4 or 5 years duration and maybe change environment when they leave the facility are able to sustain their recovery. There are relapses, but maybe not as much as. So in our presentation, we have emphasized the TC as a model and the fact that it's a community that can take 1,200 or 300 people. It's able to match the increasing army of substance use challenges that we're having in the communities. And the most important aspect of the San Patrignano community is that it's free of charge. You know, they raise, they're able to have foundations. You know, even the prison system or the correctional system in Italy even send clients to the community, you know, because they've seen that the correctional system may not have all it takes to do that. So through examination, lessons might be offered on how to promote best addiction treatment for those left most vulnerable within our society. And finally, like we said, it is how to adapt some of these successes and export it. It has been exported to the US in Scotland, and we recommend that such can happen in our country, Nigeria. I thank you very much, sir, for the privilege of
Okay. Thank you so much.
Yes, sir.
Mr. Augustine, for that insightful presentation. This is the size of our presentation today because of time, and we have a couple of questions. But before we attend to some of those comments and questions, I would like to hand over to Dr. Martin, if he has anything to say. Hello, Dr. Martins. Okay.
Yeah, Ejikeme, thank you so much, and thank you, Austin, for that insightful presentation. So, Ejikeme, please, you can go ahead.
Okay, thank you so much, Dr. Martins. Yeah, we have quite a lot of comments here. A lot of people are really excited about the presentation today, and they are hopeful that therapeutic community model is the way to go in treating substance use disorder. There are quite some questions here. The first question is coming from Oleski Kunienko from Ukraine. And the question is, why not use environmental psychology for drug addictive use instead of therapeutic community?
Okay.
Hello, Mr.
Can I respond?
Yeah, you can respond.
Yes. Okay, the question is, why not
use environmental psychology instead of therapeutic community model? Hello?
and all that? It's an environment, and we have said that that community is a method, is a context, but the relationship that is structured and that are encouraged within the community the environment he's mentioned is also embedded in the therapeutic community model.
Okay, thank you so much for that answer. Let's quickly go to the next question. Still coming from Oleski. The question is, you mentioned about different models of planning treatment of patients with mental health disorders. Do you see the difference between clinical psychology, health psychology, and the possibilities of combining the different approaches for drug patients?
Okay, I should go ahead.
Yeah, you can answer the question, please.
Okay. My understanding of his question is clinical, the importance of clinical approaches. Okay, that I mentioned various approaches, of course, during the beginning. Do I see the possibility of combining them? Definitely, definitely. We are not saying that a therapeutic community, that there will not be clinical psychologists or so. We've been saying in those approaches that, for instance, it was mentioned that the needle and syringe exchange program addresses HIV AIDS transmission and all that. It's an additional model to support in the other one. So when we have clinical methods, of course, there are clients that will come. You don't just bring a client that maybe is psychotic or so and leave him or her and throw him into the community and allow him to heal just by the community. There are psychologists and professionals in the TCs. And in fact, I made an inquiry in San Patrignano recently, and I was actually informed that they will need to even speak with the client in question, because they accept clients all over the whole world. What they need to do is Skype conversation with the client and be able to assess his status, and possibly, of course, be able to offer medical clinical assistance before the community is left to do the healing. That's my appreciation to that. We are not saying abandon clinicals. Yes.
Okay, let's just see if we can take this one more question before we round up. This is coming from Kehinde Oderinde. He said, "Thank you so much, Mr. Nduka, for the insightful lecture. How can we integrate therapeutic communities into existing healthcare infrastructure in Nigeria?"
Okay, thank you so much once again, my brother Oderinde. In fact, I have actually seen a presentation where it was kind of implemented either in Aro Abeokuta and also in, I think, UBTH also. Like we tried to mention, the understanding the very nature of the therapeutic community makes you to be able to plan, because, for instance, my own experience, which may not really be what's obtainable, and when I take patients to a mental health hospital, you'll find that they are always within their enclosed space, of course, managed with medication-assisted therapies in another. In therapeutic community, it's very possible to now start looking at structures and systems, trying to train people to understand this system, then trying to adapt and implement around the hospital environment. And it will start by implementing it among the first set of clients, teaching them values, the staff being able to understand that they are role models, then having vocational programs like in San Patrignano. You know, they have more than 50 or more vocational outlets. Then people go and learn a skill. People wake up in the morning. If they are good in dancing, they go to the dance theater. Then there's a place where they come and have dinner together. I saw some of the pictures in San Patrignano, 1,500 residents in one single community and social enterprise model. So the challenge now is that our hospital system have already been built. There's a wall already. And if you want to expand to get a workshop or to expand to now get probably a dining center, you know, from the few hospitals I've taken clients to when I was in Enugu and when I was in Ondo State, you know, these things are not planned. So it actually needs a study of the model, and of course, it's possible to implement that. Sir.
It's all right. Thank you so much.
Thank you, Ejike.
The size of our presentation today. Unfortunately, we still have a lot of questions. There's this one from Simon Mulonga that asked an interesting question. What is the disadvantages of therapeutic community? Well, we may not be able to answer those questions again because of time. We are going to come your way again. And until then, have a wonderful and lovely day. Bye-bye.
Thank you, Ejike, and thank you, my president, and Kwado, and thank you so much, sir.
Okay, so Dr. Martins, please, do you have any parting words for our attendees? Okay, I'm not sure he's around. So this is the end of our webinar today. Thank you for attending. Have a wonderful day. Bye-bye.